Imagine an organ that's just sitting there bare, like completely unprotected, right next to your beating heart.
No armor at all.
Yeah, exactly. No biological wrapper, nothing. Because, if a surgeon makes like a millimeter mistake on your intestines,
Yeah.
your body can usually kind of handle it. It can contain the leak.
Great, the surrounding tissues just sort of pitch in.
Exactly. They seal the gap, localize the damage. But if they make that exact same mistake on the esophagus, digestive acid and bacteria just spill directly into the center of your chest.
It's terrifying.
It really is. So today we are exploring an organ that is deceptively simple in concept. It's just, a 25-centimeter muscular tube connecting your mouth to your stomach.
Right.
But it is brutally, terrifyingly unforgiving when things go wrong.
Brutal is, it's a perfect word for it, honestly. The esophagus is this active transport highway that we just completely ignore until it malfunctions.
Yeah, you never think about swallowing.
Never. And when it does malfunction, it demands your absolute attention. And that's primarily because of that glaring architectural flaw you just mentioned right at the top.
Right. Well, we're working from a phenomenal source today for you, the listener. It's a comprehensive medical overview of esophageal disorders. It was originally compiled for surgical students.
A really deep, detailed text.
So detailed. And our mission for this deep dive is to basically decode the mechanics of swallowing. We're going to break down the fascinating and, frankly, sometimes terrifying ways this system crashes.
And there are a lot of ways.
So many. By the end of this conversation, the goal is to equip you with the diagnostic superpowers, to look at a set of symptoms and instantly tell the difference between, like, a functional glitch in the muscle's programming and an actual physical mechanical blockade.
Which is such a vital clinical distinction to master. You're treating a motility problem with a mechanical solution, or, vice versa. That can be catastrophic for the patient.
Yeah, you don't want to get those mixed up.
Definitely not. Yeah. But before we get into the actual diagnostics, we really need to unpack that architectural flaw, because it kind of governs everything about how dangerous esophageal diseases are.
Right, the lack of a serosa.
Yes.
Because most of the organs in the abdomen, like the stomach, the small intestine, the colon, they're all wrapped in this glistening, protective outer layer.
The peritoneal layer.
Right, the serosa.
Oh, yeah.
I always picture it like the heavy-duty rubber insulation around a live electrical wire. It contains the organ, it prevents friction with neighboring tissues, and it acts as like a biological firewall.
It is a phenomenal defense mechanism.
Yeah.
The body is smart that way, but the esophagus, it simply doesn't have it.
Just skip that step in evolution.
Pretty much. It is a bare wire sitting right there in the mediastinum.
Yeah.
Which is, the central compartment of the thoracic cavity.
The highest grant real estate in the body.
Oh, without a doubt. It's surrounded by the aorta, the trachea, the lungs, and the heart.
Which instantly clarifies why esophageal cancer is so notoriously lethal.
It really does.
Because without that serosal wrapper to act as a boundary line, malignant cells they face zero physical resistance.
Not at all.
They don't have to break through an outer casing. They just grow straight outward and immediately invade all those surrounding vital structures.
Right. And so a tumor can silently infiltrate the windpipe, or like a major blood vessel, before the patient even feels a lump in their throat.
Wow.
And it also explains why post-surgical leaks here are just a surgeon's absolute worst nightmare.
Because there's no backup system.
Exactly. If a suture line fails after, say, an intestinal surgery, the serosa and the surrounding fatty tissues can often wall off the infection, right? They create a localized abscess.
Which is bad, but manageable.
Right. But if the esophagus leaks, there is zero containment. Saliva, ingested food, stomach acid, and incredibly virulent oral bacteria, they all just pour directly into the mediastinum.
Just right into the chest cavity.
Yeah, and it causes mediastinitis. It's an overwhelming, life-threatening infection that carries a really massive mortality rate.
So we are dealing with a bare wire highway. And let's look at how this highway actually operates, because, it's not just a gravity chute. Food doesn't just fall into your stomach.
No, not at all.
It is an active transport system. And at the end of that highway sits a critical toll booth, the lower esophageal sphincter, or the LES.
Right, the LES.
And our first major disorder happens when this toll booth essentially goes on strike and absolutely refuses to open. The condition is called achalasia.
Achalasia. It literally translates from Greek as failure to relax.
Which is very on the nose.
Very. It is a profound failure of the inhibitory nervous system within the esophagus.
So I want to dig into the cellular mechanics of that failure because the wall of the esophagus contains its own local neural network, right?
It does.
Barbeck's plexus, and
Yeah.
the myenteric plexus, I think it's also called. And this network sits sandwiched right between the circular and longitudinal muscle layers, kind of acting as the local traffic control center.
Exactly. It's calling the shots locally.
So normally when you take a bite of food, the ganglion cells in this plexus release specific inhibitory neurotransmitters. The big ones are vasoactive intestinal peptide VIP and nitric oxide.
Right. And those two molecules, VIP and nitric oxide, they are basically the keys to the toll booth.
Okay.
They flood the neuromuscular junction and instruct the smooth muscle of the lower esophageal sphincter to drop its resting tone. The barricade lifts, and the food passes seamlessly into the stomach.
But achalasia is essentially this targeted neurodegenerative disease. For reasons we don't even fully understand, the specific ganglion cells in Auerbach's plexus that produce the VIP and nitric oxide, they just die off.
It's just degenerate, yeah.
So the excitatory nerves that tell the muscle to contract, those are still perfectly fine, but the inhibitory brakes are just completely gone.
The resulting imbalance is severe. I mean, without the chemical signal to relax, the LES stays permanently clenched.
It's a constant cramp.
Exactly. It goes into a state of hypertonic contraction.
Yeah.
And furthermore, that same neural network coordinates the cascading wave-like muscle contractions we call peristalsis, the waves that push food down the tube.
Right.
So when the network degrades, peristalsis in the body of the esophagus vanishes too.
So the active transport highway just shuts down entirely. The tow trucks disappear, the toll booth is jammed shut, and the esophagus essentially becomes a stagnant bag.
A stagnant bag, yes.
Food goes in, it stacks up, and nothing comes out. Which brings us to the first major diagnostic superpower for you listening. According to the surgical sources, there is one ultimate clinical clue that points straight to achalasia.
It's the dysphagia.
Right, a very specific presentation of difficulty swallowing.
The golden rule in esophageal diagnostics is always the timeline of the dysphagia. In achalasia, the patient experiences severe difficulty swallowing both solids and liquids from day one.
See, that feels incredibly counterintuitive on the surface. You would naturally assume that if a valve is clamped tight, a solid piece of steak would get stuck, sure. But wouldn't water just sort of trickle through the tiny remaining opening? Why does a glass of water get trapped just as easily as solid food?
Well, it comes back to the fact that the esophagus defies gravity. Even a liquid like water requires a coordinated, powerful muscular wave to overcome the resting pressure of a normal LES.
Oh, I see. It has to be pushed.
Exactly. So when the peristaltic programming is deleted and the valve is clenched, water simply pulls in that dilated esophageal bag right alongside the solid food.
Okay, let's contrast that with a mechanical obstruction then. Say a patient has a tumor growing inside the lumen, or maybe a web of scar tissue slowly choking off the tube.
Right, a physical roadblock.
That's going to present entirely differently, isn't it?
Totally differently. A mechanical blockage creates a progressive narrowing. So initially, the hole is still fairly large.
Makes sense.
So the patient notices large, solid things getting stuck first. They stop eating dry chicken or tough meat. But liquids and soft foods can easily slide past the physical obstacle.
So they might just naturally switch to smoothies and soups and survive on that for months.
Exactly. And only much later, when the tumor has grown so large that the lumen is practically microscopic, do the liquids finally get stuck.
That is such a brilliant clinical distinction. So if a patient walks in and says, yeah, I had to give up steak 6 months ago and today I can barely swallow water, you are immediately suspecting a hardware problem, a physical blockage.
A tumor or a stricture, yeah.
But if a 30-year-old patient comes in and says, from the exact moment this started, a sip of water gets trapped in my chest just as stubbornly as a piece of bread, you are looking at a software problem.
Exactly. The muscles just forgot how to work.
Wow. And along with that classic symptom, the sources mention that the retained food ferments.
Oh, yes.
Patients suffer from regurgitation, but it's fundamentally different from typical acid reflux.
Very different. They are bringing up completely undigested, non-acidic food that never even reached the stomach.
Just rotting in the chest.
Basically. They experience significant weight loss, obviously.
Huh.
But most dangerously, they develop a nocturnal cough.
Because they're lying flat.
Right. When they lie flat to sleep, that stagnant column of rotting food and fluid overflows the top of the esophagus and just spills into the back of the throat. If they aspirate that fluid into their lungs, they can develop a devastating aspiration pneumonia.
So once you suspect achalasia, based on that solids and liquids symptom, how do you definitively prove it? I know the barium swallow is the classic first step.
Yeah, the barium swallow.
Where the patient drinks that thick, chalky, radiopaque liquid and you watch its transit on an X-ray in real time. The visual evidence for this is legendary.
Radiologists love this one. They describe it as the bird-beak, or the rat tail sign, though the comparison to a cobra about to strike is also incredibly vivid and accurate.
I love the cobra analogy because the body of the esophagus is massively dilated, right? It's bloated and stretched out from years of food pooling in it, forming that wide hood of the cobra. But right at the bottom, at the level of the diaphragm where the LES is clenched shut, the column of barium tapers down to this perfect, smooth, incredibly tight point, the bird's beak.
And that smooth tapering is the critical detail here. It indicates that the muscle itself is just tight. It's not being irregularly chewed up by a tumor.
Okay, that makes sense.
However, a barium swallow is ultimately just a shadow on an X-ray. To truly diagnose a functional motility problem, you must directly measure the function. You need the gold standard test.
High-resolution manometry.
Right, manometry, which involves passing a thin catheter down the patient's nose, through the esophagus and into the stomach. And this thing is lined with dozens of micropressure sensors, right, like spaced a centimeter apart?
Yes, all the way down.
So as the patient takes small sips of water, those sensors map out the exact pressure dynamics and the timing of the entire esophagus in real time. It translates all those muscle contractions into a colorful topographical pressure map.
It's amazing. It allows us to basically watch the software run line by line.
And in classic achalasia, the manometry data will unequivocally show three things. First, the resting pressure of the lower esophageal sphincter will be abnormally high, typically above 45 millimeters of mercury.
Way too tight.
Right. Second, when the patient actually initiates a swallow, that pressure will not drop. There is incomplete or completely absent relaxation.
The door stays closed.
And third, all the sensors in the body of the esophagus will just register a flat line or simply mirror the baseline pressure of the chest. Yep. There are zero coordinated peristaltic waves.
Now, the sources mention the Chicago classification, version 4.0, which divides achalasia into 3 distinct types based on this manometry data. So it suggests that the software can actually crash in a few different ways.
It can.
And identifying the specific type of crash dictates the treatment approach, right?
Exactly. So type I is your classic achalasia. The esophagus is completely given up. There is no peristalsis, no muscular tone left at all. It is just a limp, dilated bag sitting above a tightly closed sphincter.
And then type 2s is the most common variant, right? This is where the esophagus is still kind of trying to fight back against the blockage.
Right. In type 2, the ganglion cells are dying, but the esophageal muscle itself hasn't exhausted its tone yet. So when the patient swallows, the entire tube tenses up all at once, desperately trying to force the bolus of food through that closed sphincter.
Just a massive squeeze.
Yeah. On the manometry color plot, we see this as panesophageal pressurization. The entire length of the tube pressurizes simultaneously. And interestingly, if a patient has to have achalasia, type 2 is actually the one to hope for.
Really? Why is that?
Because it responds best to intervention. The muscle still has some life in it.
Ah, okay. And then there's type 3, which the sources call spastic achalasia, which honestly sounds like absolute chaos.
It is the most erratic presentation by far. The LES is stubbornly closed,
Yeah.
but instead of the esophagus being completely dead like type 1 or uniformly pressurized like type 2, the muscle throws these wild, premature, spastic contractions.
It's just violently spasming against a closed door.
Exactly. And this type is notoriously difficult to treat because the problem extends far up into the chest, well beyond just that lower sphincter.
Okay, so before we discuss how to treat these, there is a massive warning flashing in the source material. We have to talk about the imposter.
Pseudoachalasia.
Right. This is the exact reason why a doctor can never just look at a barium swallow and a manometry report and call it a day, because something else can perfectly mimic this exact software crash.
Yes. Carcinoma of the cardia.
A cancer.
A very specific one. The cardia is the very top section of the stomach, exactly where the esophagus inserts into it. If a malignant tumor begins growing in that specific location, it can physically infiltrate the muscular wall of the LES, mechanically choking it tight.
But wait, how does that mimic the manometry flatline?
Because the cancer cells also destroy the local Auerbach's nerve plexus as they invade the tissue.
Oh.
They essentially delete the software locally. So on manometry, the LES doesn't relax, and the esophagus above it stops working. It looks completely identical to achalasia on a pressure map.
But it is actually a lethal invasive cancer.
Exactly. Missing a diagnosis of pseudoachalasia is a fatal error. This is why every single patient suspected of having achalasia must undergo a mandatory upper endoscopy.
You have to get eyes on it.
You have to.
Yeah.
A gastroenterologist must put a camera down the esophagus, visually inspect the mucosa, and navigate into the stomach to ensure there isn't a tumor lurking right at the junction. And a CT scan of the chest and abdomen is also standard, just to look for hidden masses or thickened walls.
Okay, so assuming the endoscopy is clear, the imposter is ruled out, and we have confirmed genuine achalasia. We are left with a permanent hypertonic muscle cramp.
Right.
The sources outline a step-up ladder of treatments, and the lowest rung is medical management using drugs that relax smooth muscle, like calcium channel blockers or long-acting nitrates.
But the pharmacological approach is generally poor, to be honest.
Really? It just doesn't work well.
Well, these drugs do force the smooth muscle in the LES to temporarily loosen, which allows some food to pass. However, the systemic side effects are significant. Patients often suffer from severe, debilitating headaches and dangerous drops in blood pressure.
Because it's relaxing all the smooth muscle in the body, not just the esophagus.
Exactly. Furthermore, the body builds a tolerance to these drugs really quickly. So medical therapy is strictly reserved as a temporary bridge to a more definitive procedure, or maybe for frail patients who just cannot survive any physical intervention.
Okay, so the next rung up sounds a bit more aggressive, but still non-surgical. Botox injections.
Yeah.
Now, we usually associate botulinum toxin with paralyzing facial muscles to smooth out wrinkles, but here we are utilizing that exact same paralytic mechanism to force the toll tooth open.
Right. The gastroenterologist uses an endoscope to inject the Botox directly into the 4 quadrants of the lower esophageal sphincter. The toxin works by permanently blocking the presynaptic release of acetylcholine, which is the excitatory neurotransmitter that causes the muscle to contract. Since the disease already killed off the inhibitory nerves, we're artificially knocking out the excitatory nerves to balance the equation.
Oh, that makes sense. You just paralyze the muscle that won't relax.
Exactly. The muscle goes flaccid, and gravity can finally pull the food into the stomach.
It sounds like an elegant, incisionless solution, but the biology of the human body kind of ruins it, doesn't it?
Unfortunately, yes. The nerve endings eventually sprout new connections, completely bypassing the paralyzed terminals, and the effect wears off in about 6 to 12 months.
So the patient has to keep coming back for repeated injections.
Yeah. It is an excellent low-risk option for an 85-year-old patient with multiple comorbidities who wouldn't survive general anesthesia. But for a 30-year-old, committing to a lifetime of biannual endoscopies is not a sustainable cure.
Which brings us to the mechanical interventions. The first is pneumatic dilatation. The source material describes this as forceful balloon dilatation. It sounds conceptually similar to an angioplasty clearing a blocked artery, right?
Conceptually, yes. But the physical reality here is far more violent.
Violent.
Yes. In an angioplasty, we are just compressing plaque against the wall of a vessel. In pneumatic dilatation, we are purposefully destroying tissue.
Wow.
Under fluoroscopic X-ray guidance, a tough, non-compliant balloon, typically 3 to 4 centimeters in diameter, is positioned perfectly across the LES. Once in place, it is inflated rapidly and forcefully to a specific high pressure.
So the goal isn't to stretch the muscle, it is literally to tear it.
We are intentionally rupturing the circular muscle fibers of the lower esophageal sphincter from the inside out.
Yeah.
By physically breaking those muscle bands, they can no longer generate the force required to stay clenched shut.
Tearing a muscle blind from the inside using a high-pressure balloon sounds incredibly risky, especially considering the whole lack of a serosa we discussed earlier.
The risk is very substantial. There is a recognized 2 to 5% chance of transmural perforation, meaning tearing a hole entirely through the esophageal wall.
Oh, no.
And that is an immediate, catastrophic surgical emergency requiring the patient's chest to be opened right then and there to repair the leak.
That's a huge risk.
It is. And even when the dilatation is successful, the body heals tears with scar tissue. As that scar tissue contracts over the years, the stricture often returns anyway. Up to a third of patients will require repeat dilatations.
So if pills fail, Botox wears off, and controlled tearing carries the risk of blowing a hole in the chest. What is the surgical gold standard here?
It is an operation called a Heller's cardiomyotomy.
Developed over a century ago by Ernst Heller, right? And it remains the most durable treatment.
It really does. Today, it is performed laparoscopically through 5 tiny incisions in the abdomen. The surgeon carefully dissects the lower esophagus and the upper stomach. Then they make a precise longitudinal cut down the front of the esophagus.
Just slicing straight through the outer longitudinal muscle and the inner circular muscle.
Exactly.
But slicing the muscle while absolutely avoiding the delicate inner mucosal lining, it sounds like diffusing a bomb. You have to cut the outer casing without nicking the inner tube.
That is an excellent analogy. The surgeon divides the tight muscle fibers over a length of about 6 centimeters on the esophagus, and then they extend that cut 2 to 3 centimeters down onto the stomach wall.
To ensure the whole sphincter is disabled.
Right. And the intact inner mucosa literally bulges out through the newly created window in the muscle. The sphincter pops open permanently.
So you've physically destroyed the tool booth. Traffic can flow freely into the stomach. But there is a massive biological consequence to this, isn't there?
A huge one.
Because if you destroy the high-pressure zone that keeps food moving down, you have simultaneously destroyed the crucial anti-reflux barrier that keeps stomach acid from shooting back up.
Precisely. You have traded dysphagia for guaranteed catastrophic gastroesophageal reflux disease, or GERD.
And left unchecked, that acid will relentlessly burn the unprotected esophagus.
Right, which is why a surgeon performing a Hellermyotomy must always pair it with a partial fundoplication.
A fundoplication, meaning they take the top floppy portion of the stomach, the fundus, and use it as building material.
Yes. They mobilize the fundus and wrap it partially around the newly exposed mucosa at the base of the esophagus. They might wrap it over the front, which is called a door fundoplication, or pull it behind the esophagus, known as a two-ped fundoplication.
But why only partially? I mean, if the goal is to stop reflux, why not do a full 360-degree wrap around the esophagus to really seal it?
It's a balance. A full 360-degree wrap, known as a Nissen fundoplication, creates a very strong, tight valve. But a patient with achalasia has a paralyzed, weak esophagus that cannot generate peristalsis.
Oh, right. The way is gone.
Exactly. If you put a tight Nissen wrap at the bottom, their weak esophagus will never be able to push food through it. You would cure their reflux, but immediately bring back their severe dysphagia.
You'd just be replacing one blockade with another.
Right. So the partial wrap provides just enough gentle pressure to stop the acid splashing up without creating a new physical blockade.
Now, there is a newer procedure detailed in the sources that approaches this from an entirely different angle. POEM, peroral endoscopic myotomy. It's often hailed as the frontier of esophageal surgery because it is completely incisionless from the outside.
POEM is a true marvel of advanced endoscopy. Instead of going through the abdomen, a highly specialized gastroenterologist or surgeon passes an endoscope down the patient's mouth. About halfway down the esophagus, they use a microscopic electrified knife to cut a tiny slit in the innermost mucosal lining.
So they don't cut the muscle yet, they just enter the wall.
Correct. They inject blue-dyed fluid into the submucosal space, which is the spongy layer between the inner lining and the outer muscle. They burrow the endoscope into that space and tunnel their way downward entirely inside the wall of the esophagus until they reach the stomach.
It's like a mole tunneling under a garden. The surface of the lawn remains completely untouched, but the mole is navigating underneath.
That's exactly what it's like. And once that submucosal tunnel is created, the endoscopist turns their knife toward the muscle layer and slices it from the inside, severing the tight circular fibers all the way down through the LES.
Wow.
When the myotomy is complete, they back the scope out and simply close the tiny entry slit at the top with a few endoscopic clips.
It is incredibly elegant, and I imagine it is especially brilliant for that chaotic type 3 spastic achalasia we discussed earlier.
It's perfect for it.
Right, because in a laparoscopic Hellermyotomy, the surgeon can only reach so high up into the chest from the abdomen. But with POEM, because the endoscope is already inside the chest, they can make that internal tunnel as long as they want, cutting all the spastic muscle fibers high up behind the heart.
For type 3 achalasia, POEM is rapidly becoming the undisputed treatment of choice. But the elegance of the procedure comes with a significant anatomical trade-off.
The catch. Because you haven't opened the abdomen and you haven't mobilized the stomach, you have absolutely no way to build that partial fundoplication wrap.
Exactly. You have cured the dysphagia by destroying the sphincter from the inside, but you have left the patient completely defenseless against stomach acid.
Right.
There is no anti-reflux procedure possible with a standard POEM. Consequently, a massive percentage of these patients develop severe post-procedure GERD. They're essentially trading their inability to swallow for a lifetime dependency on high-dose proton pump inhibitor medications just to chemically suppress their stomach acid.
It's a huge trade-off. So we just spent a lot of time analyzing a muscle that refuses to work, resulting in a stagnant tube. But the clinical picture gets even more perplexing when we look at the opposite extreme. What happens when the muscles of the esophagus don't fail to relax, but instead become wildly overactive or totally uncoordinated?
Right, now we enter the realm of the hypercontractile motility disorders. And these conditions routinely mimic completely different, often life-threatening medical emergencies.
The most infamous of these is diffuse esophageal spasm, or DEES. The sources label this the great imposter. So picture a middle-aged patient who jolts awake at 2 a.m. They are experiencing severe, crushing pain radiating behind their breastbone. They are sweating profusely, gripping their chest, and they feel a terrifying tightness in their throat.
I mean, any paramedic, emergency room physician, or even a rational bystander is going to look at that clinical picture and immediately suspect an acute coronary syndrome, a massive heart attack.
Naturally.
The patient is rushed to the resuscitation bay, they're hooked up to an ECG, their blood is drawn to check for cardiac enzymes like troponin.
And the results come back pristine, the heart is beating perfectly, the coronary arteries are wide open.
Exactly. Once the cardiac workup is totally negative, a thorough history might reveal that this crushing pain often hits them while eating, or specifically when they swallow something ice cold or piping hot.
So that thermal trigger is a massive clue pointing straight to diffuse esophageal spasm.
A huge clue, yes.
Let's compare the mechanics of DES to achalasia. In achalasia, the LES toll booth was broken. It wouldn't open. But in DES, the software running the LES actually works perfectly, right? The sphincter relaxes exactly when it should.
Right. The catastrophic failure here is in the highway itself.
Okay, how so?
Normal peristalsis is a beautiful cascading sequence of muscle contractions. It moves longitudinally down the tube, segment by segment, systematically stripping the food downward. In DES, that sequential programming crashes. The local nervous system fires the contraction signal to the entire length of the esophagus at the exact same millisecond.
So the entire muscular tube violently cramps simultaneously. It's just a massive, uncoordinated spasm.
Exactly. And the esophagus is densely innervated with visceral pain receptors. So when the entire organ goes into a sudden high-pressure ischemic cramp, those receptors fire intensely.
And the brain gets confused.
Very. The brain isn't great at precisely localizing internal organ pain, so it interprets that massive signal almost identically to the ischemic pain of a dying heart muscle.
That is terrifying. But how do you capture visual evidence of a sporadic spasm? I mean, if you send this patient for a barium swallow, what does a simultaneous contraction even look like on the screen?
Because the esophagus is contracting violently at multiple random points all at once, the barium gets squeezed and trapped in the small, relaxed pockets between the spasms.
Oh, wow.
So the smooth tube suddenly contorts into a shape that looks exactly like a corkscrew or a string of rosary beads. It is one of the most striking and famous radiological images in all of medicine.
The corkscrew esophagus. But I imagine high-resolution manometry is still required to confirm the actual pressure dynamics, right?
Yes, absolutely. On the manometry color plot, you won't see the flat line of achalasia. Instead, you will see massive simultaneous vertical columns of pressure occurring across all the sensors at once.
The pressure everywhere.
Yes. And critically, these spastic swallows are interspersed with totally normal, cascading swallows, because DES is an episodic disorder. Between attacks, the patient's software basically reboots and they swallow perfectly normally.
Treating a sporadic, violent cramp seems incredibly frustrating, though. You can't just cut the muscle if it works normally 80% of the time.
No, you can't. So we usually start with smooth muscle relaxants, like long-acting nitrates or calcium channel blockers.
Same as the early achalasia meds.
Exactly. And if a specific segment of the esophagus is identified as the primary trigger zone on manometry, we might inject Botox into that specific area to dull the spasm. In the most severe medically refractory cases, a highly extended POEM procedure can be performed, tunneling down and severing the circular muscle fibers along the entire length of the spastic segment.
Okay, so while DES is chaotic and uncoordinated, there is another hypercontractile disorder in the sources that sounds even more astonishing in its sheer brute force, Nutcracker esophagus, which the newer Chicago classification aptly renamed Jackhammer esophagus.
The terminology alone tells you everything you need to know about the immense kinetic energy involved here.
Seriously. Because unlike DES, which is chaotic, or achalasia, which is dead, the peristalsis in a jackhammer esophagus is actually present and perfectly sequenced, isn't it? The wave moves smoothly from top to bottom.
It does. The sequence is fine. The problem is that the force of the contraction is completely absurd.
It is Abnormally, violently forceful. We are talking about the smooth muscle of the esophagus generating the highest amplitude contractions found anywhere in the human gastrointestinal tract.
To quantify that violence, manometry utilizes a metric called the distal contractile integral, or DCI. It's a complex calculation that combines the amplitude of the squeeze, the duration of the squeeze, and the length of the esophageal segment involved.
Okay, so what's normal?
A healthy, normal swallow generates a DCI of under 5,000 millimeter mercury second centimeters.
Okay, under 5,000. What kind of numbers are we seeing in a jackhammer esophagus?
To meet the diagnostic criteria for jackhammer esophagus, the DCI must exceed 8,000. But in clinical practice, we routinely see patients hitting 10,000, 15,000, even 20,000 DCI.
20,000, that's 4 times normal.
The muscle is literally generating pressures high enough to crush a solid nut, hence the original name.
I have to pause and push back on the underlying logic here. If the muscles are contracting in the correct sequence, and they are successfully stripping the food down into the stomach, they're just doing it with Herculean force, why does it cause the patient such agonizing pain? And more importantly, what biological mechanism triggers a smooth muscle to suddenly adopt this hydraulic press superpower?
That is the pivotal question, and it drags us straight into one of those complex frontiers of modern medicine, the brain-gut axis.
The brain-gut axis, okay.
The extreme pain these patients feel is deeply tied to a phenomenon known as visceral hypersensitivity.
Visceral hypersensitivity, meaning the internal organs are hyperreactive to normal stimuli.
Not exactly. The nerves in the esophagus are accurately picking up the intense pressure of the squeeze, but the brain is inappropriately amplifying the incoming signal.
Oh, I see.
What the brain should process as a strong, effective swallow is instead distorted and registered as agonizing, crushing chest pain.
And the trigger for that hypercontraction, where does that 20,000 DCI come from?
It is heavily intertwined with psychosocial factors. Severe chronic stress, acute anxiety, emotional trauma, and depression are major recognized triggers.
Wow.
The pain is undeniably real and physical, but its root cause is deeply tied to the patient's neurological and emotional state. The brain is overwhelmed and it misfires, sending chaotic, hyperamplified signals down the vagus nerve to the enteric nervous system of the esophagus, commanding it to squeeze with every ounce of force it has.
So the local software in the chest hasn't actually crashed. The mainframe in the skull is overwhelmed and is actively sending a corrupted file down to the esophageal hardware.
Exactly. The emotional center of the brain is physically manifesting psychological distress into the smooth muscle of the digestive tract.
That drastically changes the treatment paradigm. You can't fix a stressed brain by cutting a muscle in the chest.
Exactly why surgery is almost never the first-line answer for jackhammer esophagus. We have to address the psychosomatic link. We utilize neuromodulators, specifically low doses of tricyclic antidepressants like amitriptyline.
We are prescribing antidepressants to treat a swallowing disorder.
Yes, but not necessarily to treat clinical depression. At very low doses, these medications act on the central nervous system to alter how the brain perceives visceral pain signals from the spinal cord.
Oh, they change the reception.
They effectively dial down the volume on that hypersensitivity. By calming the brain's reception of the signal, the physical spasms often subside. We pair this with standard muscle relaxants and aggressive treatment of any underlying acid reflux, which can act as a physical irritant that triggers the spasms.
It is a stunning reminder of how interconnected the human machine is. You can't just stare at the tube on an X-ray. You have to evaluate the nervous system attached to it.
Always.
Which transitions us perfectly into understanding what happens when that physical tube finally reaches its breaking point. Because we have established that these motility disorders can generate 20,000 DCI of chaotic pressure, biological tissue can only absorb that kind of kinetic energy for so long before structural integrity fails. Where does that force go?
It seeks the path of least resistance. It eventually blows out the wall of the esophagus, creating a permanent structural pouch. In medical terminology, this is an esophageal diverticulum.
To understand how these pouches form, we have to kind of visualize the layers of the esophageal wall. We have the delicate inner mucosal lining, the spongy submucosa, and the thick outer muscular layers. The surgical sources classify these diverticula by 2 distinct physical mechanisms, pulsion and traction.
The mechanics are straightforward physics, really. Pulsion means to push forcefully from the inside out.
Okay, push from inside.
Imagine you have a tiny natural weak spot in the thick muscular armor of the esophagus. If the internal pressure spikes massively, say from a jackhammer spasm pushing against a closed sphincter, That intense pressure forces the thin intermucosal lining to bulge outward right through that tiny gap in the muscle.
It's exactly like the inner tube of a bicycle tire herniating out through a gash in the thick outer rubber casing.
A perfect physical comparison. And the resulting pouch is just the thin inner lining hanging outside the tube. Because it does not contain the thick muscular layer, pathologists classify this as a false diverticulum. It is a pressure-driven mucosal blowout.
And the traction mechanism.
Traction means to pull forcefully from the outside in. Imagine the internal pressure of the esophagus is completely normal. However, right next to the esophagus in the chest cavity, there are lymph nodes.
Right.
If those lymph nodes become severely infected, they become intensely inflamed and sticky. They literally adhere to the outer muscular wall of the esophagus.
And then as the infection clears and the lymph node heals, it turns into dense fibrotic scar tissue.
Right, and scar tissue inherently shrinks and contracts over time. As that sticky node shrivels, it physically yanks the entire wall of the esophagus outward, tenting it into a pouch. Because this mechanism pulls the outer muscle, the submucosa, and the inner mucosa all together, it is classified as a true diverticulum.
Pulsion is pushed from the inside, traction is pulled from the outside. Let's apply these mechanisms to the specific locations where they actually happen. Because the most famous pouch, the one that inevitably shows up on every single medical board exam, is Zenker's diverticulum.
Zenker's is a classic pulsion diverticulum. It occurs right at the very top of the system, at the pharyngoesophageal junction, which is the exact border where the skeletal muscles of the throat meet the smooth muscles of the esophagus.
And the sources highlight a highly specific anatomical vulnerability here called Killian's triangle. Why is this specific spot so prone to blowing out?
Well, it is a natural dehiscence, which is a structural gap in the muscular armor of the posterior throat. Above this gap, you have the thyropharyngeus muscle, which features diagonal oblique fibers that actively squeeze food downward. Right. And directly below the gap is the cricopharyngeus muscle, which makes up the upper esophageal sphincter. Its fibers run horizontally to act as a tight valve.
Diagonal fibers above, horizontal fibers below.
Exactly. And between them, right in the posterior midline, sits a diamond-shaped area where the muscle fibers are incredibly sparse. That is Killian's triangle. Now, picture an elderly patient. Over decades of wear and tear, their upper sphincter, that horizontal cricopharyngeus muscle, becomes fibrotic and stiff. It fails to relax completely when they swallow.
So the powerful diagonal muscles of the throat are slamming a bolus of food down with immense pressure, but the sphincter valve below it won't open fully, so it's high pressure against a closed door located millimeters away from a structural weak spot.
The physics are just inevitable.
Yeah.
The intermucosal lining of the throat yields to the pressure and bulges out through Killian's triangle. Over years, every single time the patient swallows, a fraction of that food gets rammed into the bulge, slowly expanding it into a massive pendulous pouch hanging down inside the back of their neck.
The visceral reality of living with a Zenker's diverticulum sounds absolutely miserable. We are talking about patients who develop a visible, squishy lump on the side of their neck. And when they press on the lump, it audibly gurgles because it is filled with trapped air and liquid.
Yes. The defining symptom is a unique type of regurgitation. The patient will eat dinner, and then 3 days later, they will suddenly regurgitate a piece of meat from that specific meal.
3 days later.
The food never reached the stomach. It just sat in the pouch at body temperature, slowly putrefying. This leads to profound halitosis, unbelievably foul breath that really isolates the patient socially.
And just like achalasia, the physical danger occurs at night. When they lie down to sleep, the rotting contents of the pouch passively overflow into their throat. They aspirate the putrid liquid into their lungs, leading to severe recurrent pneumonia. So how do surgeons resolve this? You can't just tell the patient to chew their food more thoroughly.
No, you have to eliminate the pouch, but critically, you must also eliminate the high-pressure environment that caused it. The traditional open surgical approach involves making an incision in the side of the neck, dissecting down to find the pouch, and physically amputating it with a stapler, a diverticulectomy. However, the surgeon is not finished. They must perform a cricopharyngeal myotomy.
Meaning they take a scalpel and intentionally sever that stiff horizontal upper sphincter muscle.
It is absolutely mandatory. If a surgeon just cuts off the pouch and sews up the hole, but leaves the tight sphincter intact, the high-pressure dynamics remain completely unchanged. The very next time the patient swallows, that pressure will instantly blow out a brand new pouch right through the fresh suture line.
The underlying mechanism just has to be disabled. But operating on the neck of an 85-year-old patient carries significant risks. Is there a way to diffuse this plumbing disaster without making an external incision?
There is. The modern, minimally invasive approach is an endoscopic stapling technique, often referred to as the Dolman procedure.
How does that work?
The surgeon passes a rigid, hollow metal scope through the patient's mouth and down into the throat. This exposes the common wall, the septum, that separates the normal esophagus from the diverticular pouch.
So they are looking down at a fork in the road.
Exactly. The surgeon inserts an endoscopic stapling device perfectly over that dividing septum. When they fire the stapler, it simultaneously cuts down the middle of the wall and staples the cut edges together.
Wait, so rather than trying to remove the pouch entirely, you just obliterate the wall, separating it from the main highway. You turn two separate tubes into one giant open funnel.
That's it. Food simply slides down the funnel into the esophagus instead of getting trapped in a blind alley. And the brilliance of this technique is that the tight cricopharyngeus muscle lives exactly inside that dividing wall. By cutting the wall, you automatically cut the muscle, instantly relieving the high-pressure trigger.
That's incredibly smart.
It is a profoundly elegant, rapid solution with an incredibly fast recovery time.
Okay, that covers the pulsion blowout at the top. Let's descend to the middle of the chest. Mid-esophageal diverticula. The sources locate these right at the carina, which is the exact point where the trachea splits into the left and right main bronchi. And crucially, these are traction diverticula. They are pulled from the outside.
Which means we are looking for the culprit doing the pulling. In this specific anatomical location, the esophagus is surrounded by a dense network of mediastinal lymph nodes. Historically, this pathology is deeply tied to granulomatous infections, primarily tuberculosis or histoplasmosis, which is a severe fungal infection of the lungs.
So the TB bacteria infect the lymph node. The node becomes inflamed and sticky, fusing to the outer wall of the esophagus. As the patient's immune system fights off the TB, the node heals by calcifying and forming a dense, contracted scar.
Right.
And that shriveling scar acts like a winch, physically yanking the esophageal wall outward.
For the vast majority of patients, these small traction pouches are completely asymptomatic. They are just incidental findings on an X-ray. However, in rare, severe cases, the calcified lymph node can undergo necrosis and erode straight through the tissues, creating a physical tunnel, a fistula, between the esophagus and the bronchial tree.
A tracheoesophageal fistula. So when the patient takes a drink of water, it passes through the tunnel and pours directly into their lungs.
Yes. The hallmark symptom is the patient coughing violently and uncontrollably the absolute second they try to swallow liquids. It is a devastating complication that requires complex thoracic surgery to divide the tunnel and patch both organs.
Let's move to the very bottom of the system, though. Epiphrenic diverticula, located in the lower 10 centimeters of the esophagus, just above the diaphragm. The sources classify these as pulsion diverticula, driven by extreme internal pressure. This loops us directly back to our previous discussion on motility disorders, doesn't it?
The connection is absolute. Epiphrenic diverticula are rarely standalone structural defects. They are almost universally the end-stage physical consequence of an underlying untreated motility disorder.
Like Achalasia or Jackhammer.
Exactly. Those software crashes we detailed earlier generate massive, chaotic hydraulic pressures against a closed LES. Eventually, the mucosal wall near the bottom just surrenders and herniates outward.
Which highlights a crucial surgical trap. If a surgeon discovers an epiphrenic pouch and decides to just amputate it, sew up the hole, and leave, it's exactly like patching a punctured bicycle tire without pulling the nail out of the rubber first. It is biologically doomed to fail.
It is the classic board exam scenario that separates good surgeons from great ones. If you only perform a diverticulectomy, the severe achalasia or the jackhammer spasms are still actively running their corrupted software.
So the pressure comes right back.
Within days, those 10,000 DCI pressure waves will slam against your fresh suture line and violently blow it apart. The patient will suffer a catastrophic leak of esophageal contents into the mediastinum.
So the surgical protocol has to address the entire cascade of failure simultaneously.
The mandatory surgical triad for an epiphrenic diverticulum requires 3 distinct steps. 1. Perform the diverticulectomy to remove the rotting pouch. 2. Perform a long myotomy, slicing the spastic muscle fibers or the tight LES on the opposite side of the esophagus to permanently vent the high pressure.
Right.
And 3. Perform a partial fundoplication wrap to prevent the inevitable acid reflux caused by cutting the muscle. You must fix the structural consequence and the physiological cause in the exact same operation.
We have spent the first half of this deep dive exploring the ravages of mechanical pressure, muscles clamping shut, muscles spasming, walls blowing out. But now we are shifting to an entirely different vector of destruction. What happens when the delicate inner lining of this tube is subjected to chronic, relentless chemical warfare?
We're talking about the corrosive daily assault of hydrochloric acid from the stomach.
Right. If the LES toll booth is incompetent, perhaps it's naturally weak, or perhaps the surgeon deliberately cut it to cure achalasia stomach acid, continually washes back up into the lower esophagus. Over years, this chronic chemical burn leads to a fascinating pre-malignant condition called Barrett's esophagus.
Named after the British thoracic surgeon Norman Barrett, who first described it in the 1950s. To truly grasp what Barrett's is, you have to understand the cellular mechanisms of survival. The normal, healthy lining of the human esophagus is composed of stratified squamous epithelium.
Squamous cells, I always picture them like the tough, flat cells in the back of your hand. They are stacked in multiple layers, perfectly designed to withstand the physical friction of swallowing a rough tortilla chip.
Exactly.
But they are completely chemically defenseless against acid.
All right. Conversely, the stomach is lined with columnar epithelium. Columnar cells are tall, and crucially, they secrete a thick, alkaline mucus gel layer that neutralizes acid and protects the stomach wall from digesting itself. When a patient has severe GERD, the squamous cells of the lower esophagus are bathed in caustic stomach acid day after day. They die in massive numbers, causing painful erosions and ulcers.
So the body realizes it is losing the battle. The current armor isn't working, so it makes a radical evolutionary decision at the cellular level. As the burned area heals, instead of growing back the defenseless squamous cells, the stem cells in the esophagus regenerate the tissue using acid-resistant columnar cells.
It fundamentally changes its cellular identity to adapt to the hostile acidic environment. This biological process of one mature cell type replacing another mature cell type is called metaplasia.
The esophagus is essentially trying to turn itself into a stomach to survive. But the diagnostic criteria in our sources are incredibly strict about this. Just finding columnar cells isn't enough to officially diagnose Barrett's esophagus. A pathologist looking at the biopsy under a microscope must identify one specific vital cell type, right?
Yes.
Goblet cells.
Why are goblet cells the absolute smoking gun for Barrett's?
Well, goblet cells are highly specialized, flask-shaped cells that are normally only found in the intestines. Their primary function is to synthesize and secrete massive amounts of mucin, which is the main component of protective mucus. If a biopsy of the esophagus shows columnar cells but no goblet cells, the pathologist will just call it gastric-type mucosa. The esophagus looks like a stomach.
Okay.
But if goblet cells are present, it proves the tissue has undergone intestinal metaplasia. The esophagus has mutated so far that it is mimicking the intestines. That specific intestinal metaplasia is the absolute hallmark required to formally diagnose Barrett's esophagus. To standardize how we talk about this damage, gastroenterologists use a measurement system called the Prague criteria. It sounds like a geopolitical treaty, but it's really just a way to map the battlefield.
It ensures a doctor in Tokyo and a doctor in New York describe the exact same lesion. The criteria use two measurements, C and M. The C stands for circumferential extent, measuring how many centimeters up from the stomach. The new, mutated tissue forms a complete unbroken ring around the esophagus. The M stands for maximum extent, measuring how far up the longest isolated tongue or streak of mutated tissue reaches.
So diagnosis C2M5 means there is a solid 2-centimeter ring of Barrett's with a jagged streak reaching up 5 centimeters, and the rules state you need a minimum of 1 centimeter of visible change to even apply the label. Now, on paper, this metaplasia sounds like a brilliant biological defense mechanism. The cells change to survive the acid. Why is the medical community so terrified of Barrett's esophagus?
Because cellular instability is the breeding ground for genetic mutations. By forcing the cells to constantly regenerate and change their identity in a highly inflamed environment, we open the door to the metaplasia-dysplasia carcinoma sequence.
Metaplasia, the appearance of the intestinal goblet cells, is just step one.
If the acid reflux isn't aggressively stopped, the DNA in those newly formed intestinal cells begins to accumulate errors. The cells start to grow abnormally. Under the microscope, the pathologist sees the nuclei become dark, enlarged, and crowded. The orderly architecture of the tissue breaks down into chaos. This precancerous state is called dysplasia.
And dysplasia is the direct stepping stone to cancer. The progression moves from low-grade dysplasia to high-grade dysplasia, and ultimately, the mutated cells breach the basement membrane to become fully invasive esophageal adenocarcinoma. The statistical risk laid out in the sources is chilling. If a patient just has simple Barrett's metaplasia with no dysplasia, their risk of developing cancer is relatively low, roughly 0.2 to 0.5% per year. But the moment that tissue mutates into high-grade dysplasia, the risk explodes to 6 to 10% per year.
A 10% annual risk is a massive flashing red siren in oncology. If you leave high-grade dysplasia untreated, a significant portion of those patients will develop a lethal invasive cancer within a very short window of time.
So the entire game is catching it before it breaches the membrane. If a patient has a history of severe acid reflux, how do we systematically monitor their esophagus to catch these silent mutations?
We rely on rigorous endoscopic surveillance. But we can't just take one random snippet of tissue and hope for the best. Dysplasia is often invisible to the naked eye. It hides within the pink Barrett's tissue. Therefore, we use a mandatory exhaustive sampling method called the Seattle Protocol.
Walk me through the mechanics of the Seattle Protocol.
During the endoscopy, the physician uses specialized forceps to take 4 distinct targeted biopsies at the 12, 3, 6, and 9 o'clock positions, every 2 centimeters along the entire length of the Barrett's segment.
Every 2 centimeters?
Yes. If the patient has a C2M5 segment, the doctor is taking dozens of individual biopsies. It is a meticulous, time-consuming grid search of the esophagus to guarantee that no microscopic island of high-grade dysplasia or early cancer is missed.
Okay, let's navigate the treatment algorithm based on the pathology report from that grid search. Scenario 1. The pathologist confirms Barrett's metaplasia, but finds 0 dysplasia. The cells have changed into intestinal cells, but their DNA looks stable.
The clinical strategy here is aggressive defense and watchful waiting. We immediately start the patient on high-dose proton pump inhibitors PPIs to chemically shut down the stomach's acid production, halting the ongoing chemical burn. Then we enroll the patient in a surveillance program, bringing them back for a repeat Seattle Protocol endoscopy every 3 to 5 years.
Scenario 2. The pathologist spots low-grade dysplasia. The nuclei are starting to look a little dark and crowded.
Now the alarm bells are ringing. We have 2 acceptable paths. We can step up the surveillance aggressively, repeating the exhaustive biopsies every 6 months to watch the tissue like a hawk. Or, and this is rapidly becoming the standard of care, we proactively offer endoscopic eradication therapy to destroy the mutating tissue before it can progress.
Which brings us to scenario 3, high-grade dysplasia. The 10% a year risk. The alarm bells are deafening. Surveillance is no longer an option. What are the weapons we use to eradicate this tissue without surgically removing the entire esophagus?
We have an arsenal of incredible endoscopic tools that allow us to operate entirely inside the lumen. If the gastroenterologist sees a distinct raised nodule that looks highly suspicious for early cancer, they will perform an EMR endoscopic mucosal resection.
But how do you safely slice off a nodule from a bare wire organ that is only millimeters thick?
It requires extreme precision. The doctor uses a microscopic needle to inject a cushion of saline fluid directly into the submucosal space beneath the nodule. This physically lifts the mutated lesion up and away from the deep muscle layer, creating an artificial blister.
Oh, clever.
They then loop a specialized wire snare around the base of the blister and apply an electrical current to cleanly slice the nodule off and cauterize the base simultaneously.
So you're safely shaving the bad patch off from the inside. But what if the dysplasia isn't a neat little raised bump? What if it's a wide, flat, sweeping area of mutated tissue?
For larger flat lesions, we step up to ESD endoscopic submucosal dissection. This is a highly advanced, technically demanding procedure where the endoscopist uses a microscopic electrosurgical knife to painstakingly dissect and peel away massive, contiguous sheets of the diseased inner lining, leaving the outer muscle tube completely intact.
But the absolute workhorse for treating widespread Barrett's, the tool that seems to have revolutionized this field, is RFA, radiofrequency ablation. You are essentially microwaving the inside of the esophagus to reset the biological clock.
That is precisely what we are doing. The endoscopist inserts a specialized catheter equipped with a balloon covered in tightly spaced copper electrodes. They position the balloon perfectly over the Barrett's tissue and inflate it so the electrodes make foam contact with the wall. Then, a generator delivers a highly calibrated microsecond burst of thermal radiofrequency energy.
Literally a microscopic burn.
A perfectly controlled burn. The energy is calculated to destroy tissue to a depth of exactly 1,000 microns. It instantly vaporizes the mutated epithelial cells and the superficial mucosa, but the energy stops precisely before it reaches the deep submucosa or the muscularis layer.
The precision is staggering. You burn the bad cells dead flat without causing a stricture or a perforation.
Over the next few days, that dead, mutated tissue simply slips off. And here's the biological magic. Because the patient is now on massive doses of PPIs, the environment is no longer acidic. Without the acid driving the mutation, the local stem cells regenerate normal, healthy, squamous epithelium in the treated area. We have literally reversed the disease process.
It is a profound triumph of modern medicine, because if we fail to execute that surveillance and if we fail to ablate that high-grade dysplasia before it breaches the basement membrane and becomes invasive esophageal adenocarcinoma, the medical endgame is grim.
Very. The end-stage treatment for invasive cancer is a massive, highly morbid, life-altering surgery known as an esophagectomy, operations like the Ivor-Lewis or the McEwen procedure.
I really want to emphasize the sheer scale of an esophagectomy to contrast it with the elegance of an endoscopy. We are talking about the surgeon making a massive incision in the abdomen to free up the stomach and its blood supply. Then they make another massive incision to crack open the right side of the chest, deflating the lung to access the mediastinum. They physically amputate the diseased esophagus and all the surrounding lymph nodes. Finally, they drag the stomach all the way up through the chest cavity and sew it to the tiny stump of the throat left in the neck.
It is a grueling, grueling operation. The complication rates are high, the recovery takes months, and the patient's anatomy and ability to eat are permanently, fundamentally altered. They can never eat a normal-sized meal again.
Which perfectly underscores the value of the Seattle Protocol and RFA. If a doctor meticulously takes those biopsies and burns the precancerous cells flat with a balloon, they have literally spared a human being from having their chest cracked open and their stomach pulled up into their neck. Early intervention is everything.
It is the absolute difference between a 1-hour outpatient procedure and a fight for survival in the intensive care unit.
This stark reality transitions us directly into our final major topic. We've explored what happens when the cellular identity changes. But what happens when the damage goes deeper? Whether it's driven by chronic acid, the ingestion of caustic chemicals, or the ultimate progression of Barrett's into a bulky tumor, the esophagus reacts to deep trauma by physically narrowing down. It forms a stricture.
We are leaving the realm of motility disorders and cellular mutations and entering the domain of pure mechanical hardware blockades. The surgical sources categorize these into 3 primary types: peptic strictures, corrosive strictures, and malignant strictures.
Let's start with peptic strictures because they are the direct end-stage physical consequence of the severe GERD we were just discussing.
If the acid reflux is so relentless and so severe that the chemical burn penetrates through the superficial mucosa and deep into the submucosa, the body reacts exactly like it would to a deep burn on your arm. It tries to heal the crater with dense, fibrotic scar tissue.
And as we established earlier with the traction diverticula, scar tissue naturally contracts and shrinks as it matures.
Over months and years, that circumferential ring of scar tissue at the bottom of the esophagus slowly tightens like a microscopic noose. It forms a rigid, unyielding, fibrous blockade. The most classic anatomical presentation of this is the Schottky ring, which forms exactly at the squamocolumnar junction right above the stomach.
Let's link this back to the diagnostic superpower we established in the very first section. If a patient presents with a stricture, a physical mechanical narrowing, what does the timeline of their dysphagia look like?
It is the exact opposite of achalasia. It is highly progressive and sequential. The patient will present a history that spans months or years. They will say, "A year ago, I had to chew my steak for 5 minutes to get it down. 6 months ago, I gave up meat entirely and switched to pasta. Last month, even mashed potatoes started getting stuck. And today, I struggle to swallow a thick soup."
Solids first, then semi-solids, then finally liquids. The classical signature of a shrinking hole.
Precisely. If we order a barium swallow, a peptic stricture typically presents as a very short, smooth, highly symmetrical tapering right at the distal end of the esophagus.
Treating a ring of scar tissue seems straightforward compared to cancer. You just forcefully stretch it open.
Endoscopic dilatation is the primary tool. We pass a deflated balloon through the stricture and systematically inflate it to physically fracture and stretch the fibrotic ring. However, if you simply stretch the scar and send the patient home, the ongoing acid reflux will instantly restart the burning process and the stricture will reform within weeks. Dilatation must be permanently coupled with massive doses of acid-suppressing PPIs or a definitive laparoscopic anti-reflux surgery like a fundoplication to eliminate the root cause.
Okay, peptic strictures are caused by acid splashing up from below. But what about caustic chemicals poured down from above? Corrosive strictures, the chemical burns. We are talking about scenarios where a person accidentally or intentionally swallows a harsh industrial chemical. I want to drill down into a very specific, crucial distinction made in the sources. Does the physiological damage differ if the patient swallowed a strong acid like battery acid versus a strong alkali substance like liquid drain cleaner or heavy-duty bleach?
The difference is monumental. In fact, the pH of the chemical dictates the entire catastrophic pattern of tissue destruction. There is a fundamental biological law governing how human proteins and fats react to these specific pH extremes.
Let's unpack the cellular chemistry of that law. What happens when a strong alkali hits the tissue?
Alkali substances, like sodium hydroxide, trigger a devastating process called liquefactive necrosis.
Liquefactive. It literally turns the solid tissue into a liquid.
It saponifies the fats in the cell membranes, essentially turning them into soap, and rapidly dissolves the structural proteins. It turns the highly organized esophageal wall into a gelatinous, soupy, necrotic sludge. Because this process leaves no solid biological barrier behind, the alkali chemical faces no resistance. It just continues to penetrate deeper and deeper and deeper into the wall of the organ until the chemical is completely neutralized by the surrounding tissues.
It melts its way relentlessly through the tissue. And because the esophagus is the very first organ the chemical contacts, and because the esophagus lacks that protective mucus layer we find in the stomach, the strong alkali preferentially and totally destroys the esophagus.
It is a liquefying catastrophe in the chest. Now contrast that with the ingestion of a strong acid. Acids trigger a completely different mechanism called coagulative necrosis.
Coagulative, I always imagine cooking an egg white. The clear liquid protein hits the hot pan and instantly denatures, cross-linking into a solid, opaque, rubbery mass.
That is the exact biochemical process. The intense acid denatures the superficial tissue proteins, rapidly cross-linking them into a tough, solid, leathery scab known as an ester.
And that solid scab forms a physical blockade.
Exactly. The ester actually limits the deep penetration of the acid into the wall. The acid rushes quickly down the esophagus, causing very painful but relatively superficial burns, and then it pools in the stomach. The stomach acts as a reservoir, holding the caustic acid. Therefore, strong acids preferentially cause deep destructive burns in the stomach and the pylorus, the stomach's exit valve, while largely sparing the deep muscle layers of the esophagus.
That is a fascinating, morbid axiom of toxicology. Alkali liquefies and obliterates the esophagus. Acid coagulates and obliterates the stomach. Knowing that, let's look at the acute clinical management. A patient is rushed into the emergency room having just swallowed industrial drain cleaner. The natural instinct of any doctor would be to immediately get a camera down there to assess the extent of the damage.
And acting on that natural instinct would likely kill the patient on the table.
Explain why.
Because of the liquefactive necrosis. The wall of the esophagus is currently melting into a soapy soup. It is incredibly friable. It has zero structural integrity. The mere act of insufflating air through the endoscope to inflate the tube so you can see, or the physical pressure of the camera tip lightly brushing the wall, will instantly cause a massive iatrogenic perforation. You will blow a hole straight through the melting tissue into the mediastinum. The absolute cardinal rule of acute corrosive ingestion is never perform an upper endoscopy during the acute necrotic phase.
So what are the interventions? You just stand back and watch.
You provide massive, aggressive systemic support. High-volume 4V fluids to support their failing blood pressure, profound pain control, broad-spectrum IV antibiotics to prevent mediastinitis, and powerful acid suppression to prevent any native stomach acid from worsening the burns. You might perform a very gentle fluoroscopic swallow study using a water-soluble contrast agent, never thick barium, just to see if a spontaneous perforation has already occurred. But primarily, you must let the tissue survive the acute shock and begin to stabilize.
Assuming the patient survives the acute phase, when does the physical stricture actually form?
The body attempts to heal that massive necrotic crater with granulation tissue, which over 3 to 8 weeks matures into incredibly dense, unyielding fibrotic scar tissue. And corrosive strictures are biologically brutal. Unlike the short, neat, symmetrical rings of a peptic stricture, a corrosive stricture is long, tortuous, thick, and highly irregular. It often spans massive, twisting sections of the entire esophagus.
They sound mechanically impossible to just stretch open with a balloon.
They are notoriously refractory to treatment. We attempt serial dilatation, gently stretching the dense scar tissue millimeter by millimeter every few weeks, sometimes for years. But if the stricture is too long, too thick, or too dense, the esophagus is functionally destroyed. It is a dead, solid cord. In those tragic cases, we have to perform a total esophageal replacement. We surgically pull the entire stomach up into the neck, or we harvest the long segment of the patient's colon, preserve its blood supply, string it up through the chest cavity, and use the colon as a substitute esophagus.
It is a massive, highly morbid salvage operation to restore the basic human dignity of swallowing saliva, which brings us to the final and most fatal mechanical blockade in our deep dive. Malignant strictures. This is the grim reality of advanced esophageal cancer.
We discussed Barrett's progressing to adenocarcinoma in the distal esophagus. There is also squamous cell carcinoma, which typically arises in the upper and middle thirds of the esophagus, historically driven by heavy smoking and chronic alcohol consumption. Regardless of the cell type, the end result is a chaotic, malignant tumor mass growing relentlessly inside the lumen.
The clinical presentation here is defined not just by the sequence of dysphagia, but by the terrifying speed of its progression.
A peptic stricture might take 3 years to progress from steak to soup. Malignant dysphagia is rapidly, violently progressive. Over a matter of just a few weeks, a patient will go from struggling to swallow dry bread, to struggling with soft pasta, to choking on water, to finally not even being able to swallow their own saliva. They present to the clinic constantly spitting into a cup because their esophagus is entirely occluded. The associated weight loss is profound, often leading to cachexia, severe muscle wasting.
If we look at this cancer on a barium swallow, what is the visual contrast between this and the other conditions we've mapped out?
Recall the elegant, smooth tapering of the Achalasia bird-beak. Recall the perfectly symmetric, smooth ring of the Schatzky stricture. Cancer does not respect anatomical boundaries. It is a chaotic, destructive, asymmetrical growth. The barium swallow will display a rat tail appearance, but the borders will be highly irregular, jagged, and moth-eaten. Alternatively, you will see the classic shoulder sign, or shelf sign. The column of barium hits an abrupt, sharp, asymmetric ledge where the bulky tumor mass abruptly juts out into the highway.
It is a visually violent image that perfectly reflects the pathology. What are the surgical options when the lumen is entirely blocked by a tumor?
If the cancer is caught early enough, and imaging confirms it has not metastasized to distant organs or invaded the aorta, we return to the esophagectomy. We aggressively resect the esophagus and surrounding lymph nodes for a potential cure. But tragically, because the esophagus is highly distensible and lacks a serosa, tumors often grow quite large and spread widely before they cause enough dysphagia for the patient to seek help. Many patients present in an advanced, incurable stage.
If the intent is purely palliative, if you cannot cure the cancer but you refuse to let the patient starve or choke on their own saliva, how do you physically force that blocked highway open?
We deploy a device called a SEMS, a self-expanding metal stent. Using fluoroscopic X-ray and endoscopic guidance, the physician navigates a tightly compressed, tightly wound cylinder of memory metal wire mesh directly through the center of the obstructing tumor. Once perfect positioning is confirmed, the stent is deployed. The metal mesh violently springs open, utilizing radial force to physically crush the tumor tissue outward, prying the lumen open and holding it there.
A mechanical cage holding the crushing force of the tumor at bay.
Within 24 hours of deploying that stent, a patient who couldn't swallow their own saliva can comfortably drink liquids and eat soft, pureed foods again. It doesn't cure the disease, but it restores an immeasurable amount of comfort, nutrition, and dignity during the end of their life.
We have covered a truly massive expanse of medical science today. We have journeyed down this 25-centimeter bare wire tube, starting from the skeletal muscles of the throat down to the acidic reservoir of the stomach, analyzing every conceivable way the physics, the software, and the cellular biology can collapse.
From the invisible neurodegeneration of achalasia, to the catastrophic pressure blowouts of the diverticula, to the relentless cellular mutations of Barrett's, and finally to the devastating hardware blockades of strictures and cancer.
Let's synthesize the absolute most vital diagnostic takeaway for you, the listener. If you retain only one clinical pearl from this exhaustive deep dive, let it be the timeline of dysphagia. It is the ultimate diagnostic compass. If a patient cannot swallow solid food and liquid water right from day one, if gravity completely fails them, you are dealing with a functional motility disorder. The hardware is intact, but the muscular software has crashed. It is achalasia or spasm. But if the patient struggles with large solids first, and only months later begins to struggle with soft foods and liquids, you are dealing with a mechanical blockade. The hole is physically shrinking. It is a peptic scar, a corrosive burn, or a malignant tumor.
That singular distinction dictates the entire trajectory of the patient's diagnostic workup and surgical intervention.
Before we sign off, I want to circle back to a concept that emerged during our analysis of the hypercontractors, specifically the jackhammer esophagus, because it planted a thought that I find deeply compelling, and I think it fundamentally challenges how we view gastrointestinal medicine.
You are referring to the visceral hyposensitivity.
Yes. We explore the astonishing reality that the smooth muscle of the esophagus can generate 20,000 dci of pressure force sufficient to crush a nut, purely in response to severe emotional stress, trauma, or anxiety. The human brain literally encodes its psychological distress, sends it down the vagus nerve, and executes it as a violent physical spasm in the center of the chest.
It is the ultimate physical manifestation of psychological pressure.
It raises a profoundly provocative question for all of us navigating the relentless, hyper-stressed reality of the modern world. When we experience gastrointestinal distress, when we suffer from unexplained indigestion, chronic chest tightness, or that persistent, unswallowable lump in our throat, how much of that is truly a mechanical breakdown caused by the food we consumed? And how much of it is our digestive tract physically bearing the weight of the psychological pressure we refuse to process?
It forces us to ask, is the anatomical hardware actually broken? Or is an exhausted mind simply writing chaotic, destructive code to the body?
The esophagus might just be a mirror for the mind. It is not merely a muscular transit tube. It is a highly sensitive barometer measuring the unseen stress we carry every single day. And when the muddy waters of diagnosis start swirling, and the manometry plots and barium swallows don't provide an easy answer, sometimes the solution doesn't lie within the anatomy of the tube itself. Sometimes the answer demands that we step back and examine the human being attached to it.
A powerful reminder that in the practice of medicine, you can never truly separate the function of the organ from the lived experience of the organism.
Thank you so much for joining us on this incredibly expansive deep dive into the esophageal highway. Keep questioning the why behind the wondrous, terrifying ways your body works, and we will see you on the next one.